Thank you very much, Dr. Pooja and Dr. Rohan, for my inclusion, and thanks for my friend Dr. Mehta Shimamshu for having me here. And he's the president of IRSA, which is such an important organization in the country, having such veteran surgeon, which is now trying to inspire the young ophthalmologists in the most important part of our ophthalmic practice, that is the cataract surgery and the refractive surgery. So the topic is the war that goes on between the choice between the multifocals and the monovision. I think the monovision, I think this is something which is so relevant. I'm very happy to actually speak on this topic because as a postgraduate, as an young ophthalmologist, we would ask a senior person, sir, what should I do with this patient? Should I put a multifocal or not? I do get calls from my previous fellows or people who have just joined practice. Sir, in this patient, should I put a multifocal or should I do monovision? So what do you do in this case? So this oversimplification is something which everybody wants, but you can probably never choose whether it's Virat is better or Dhoni is better. It can vary with situations and with your own likings. You can't say whether Mohammad Rafi is a better singer or a SP Balasubramaniam. The problem is that we need to actually understand the crux of the issue. The turf war continues because there has never been an answer that has been already, we have a final answer. We can never say that the multifocals is the clear winner or the monovision is actually a better bet at this point of time because the multifocals are not still, they're still evolving. They have not been perfected. I think this answer needs a little explanation. I think you know that the multifocals have their own problems. I think this is a very classical question asked to postgraduates, and postgraduates have it in their mind. They say it's the cost. So many of my postgraduates say the patient can't afford a multifocal. I think this is something that needs little discussion. I think most people, the young ophthalmologists actually, don't get the idea that this is a one-time investment by the patient. That has to be kept in the perspective. Because the patient using a near correction or whatever kind of glasses that he's using, it applies for even toric lenses for that matter. There's a cumulative effect of the patient spending for spectacles for the rest of their lifetime. That cumulative, that's a point of commerce that we need to understand, that we need to actually do a proper counseling. I think counseling is not in our curriculum for postgraduate training, not even undergraduate training. I think this is something that we need to learn the hard way. So we need to use the right kind of analogies, the right kind of words to make them understand that the cost, the extra cost the patient has to bear for having a multifocal in the eye is actually worth it because it is going to be a one-time investment. And obviously, it all depends even on the mindset of the surgeon. There are many surgeons whom I know of that they're not really warmed up to the idea of multifocals in most patients. They have their own preferences, many times not scientifically based. They have their own whims, fancies, and they think they sometimes look at a very subtle sign and they are very steadfast on their decision that I'm not going to put a multifocal on this patient. So the cost is something that should never be a problem because the present day multifocals are not very, very costly, at least in the Indian scenario. Then the decreased contrast. I think this is something that we need to use this word very carefully with the patients. Many times we do explain that what is decreased contrast. We say it's a 0 wattage bulb or a 100 wattage bulb, a 0 candle bulb or a 100 candle bulb. I think these kind of explanations or analogies can really put off the patient. No patient would like to see as if he's seeing in a 0 candle bulb situation. So the contrast, what exactly is the contrast? At the same time, many institutions or many practitioners, even postgraduates, are not exposed to the actual contrast sensitivity testing. We have never had pelliropsin charts in our clinics. We always have a Snellen's chart, which is a 100% contrast chart, black and white chart, which is never the real time or the real world scenario. So making a patient understand what is a decreased contrast is actually quite a difficult job, but this is definitely a point that a patient will complain. He may not be able to articulate it well, but you do understand that there is a definite drop in the pelliropsin number that you after the multifocal implantation, and a waxy vision. Many patients complain of this. Their vision is not as bright. Like the monofocal patients never complain of any of this. They have a crisp vision. Normally, they never complain of any kind of decrease in the quality of vision. But multifocal patients, you do have quite some patients who can actually complain, who are very observant and who are a little obsessed with their quality of vision can definitely complain. I think halos and glare is a little of an overstatement. Many people, especially the postgraduates, think that the driver should not have a multifocal in their eye. It is not necessarily so. I think people who do not drive also are definitely going to have a problem with halos and glare. What is very important for a young ophthalmologist to understand is the pupillometry. I think this is one parameter we need to measure regularly in our pre-cataract evaluation, because if the pupil dilates too much. If the patient has a very large photopic or a mesopic pupil, then you will have a different ball game compared to people who have very senile meiosis, small pupils. For them, the contrast, the halos, glare, even the aberrations of the cornea is a non-entity. I think halos and glare normally is basically, normally it's a little overhyped, and most patients actually, they do understand that it, once probably if you counsel that it kindly goes away with time. Normally after 2 to 3 months, they stop complaining. It is an initial thing. If you are seeing halos, glare, I think the easiest thing to do is I tell the patient that, are you seeing rings around light? Are you seeing halos? And that means your multifocal is working perfectly well. I think that is also a truth. But that is the way probably the patient will get convinced, and over a period of time, they do kind of get used to it, even though it may not disappear completely. There is some kind of an adaptation that happens. I think the very important thing is when you are looking for a patient for a multifocal implantation, you have to choose the patient very meticulously. I think to avoid the heartburn, both for you as well as for the patient, because a lot of effort goes in, a lot of aspirations are raised, and patient spends an extra amount of money. And definitely, if not properly chosen, the patient may end up more dissatisfied because of the extra amount of money that is involved. I think looking at the front of the eye, this is probably very important. Look at the cornea very carefully. The cornea has to be pristine, absolutely transparent. At least the central 3-4 millimeters should not have any kind of scarring or a nebular opacity, or the cornea should be pristine, very clear, transparent. That is a crystal clear cornea. At least the central cornea is an absolute necessity for a happy patient. The patient should have a regular astigmatism. If there is an astigmatism more than 0.5, it also affects the overall impact on the multifocality. So you may have to resort to a toric multifocal. But less than that, probably we can manage. But it has to be a regular astigmatism. If there's an element of irregular astigmatism, then you are going to actually have more problems. Then the monofocal is the way to go. At the same time, the aberrations. I think this is one more thing for postgraduates or young ophthalmologists, that we are now advancing in our perfection of our cataract surgery outcome. Just like Dr. Ramamurthy alluded on the newer, the frontline IOL formulae for an extremely accurate biometry readings. Similarly, we also have to look at the aberration profile of the cornea in future. Probably we will be able to manage many of our patients who are not satisfied even after a successful cataract surgery if you look into their aberration profile and choose the IOL appropriately. Maybe here there is an element of the marriage between the refractive surgery and the cataract surgery too. So we may have to probably combine multiple procedures to get an aberration-free cornea and also have a very clear or a good quality of vision. I think angle alpha has been always a problem to postgraduates because we also have another angle called angle kappa. So what is angle alpha? What is angle kappa? Fortunately, I am also a strabismologist, so probably I can tell you the difference to the postgraduates more clearly. We knew only kappa in the past. Before the advent of multifocals and before all these things came in, angle kappa is the basically the pupillary axis. That means if you draw a line perpendicular to the pupillary plane from the center of the pupil, what is called the center of the pupil. For all practical purposes, the center of the pupil actually denotes the pupillary axis to the center of the cornea. So basically, if the Hirschberg reflex, if the Hirschberg reflex is the visual axis, so visual axis and the pupillary axis. If the Hirschberg reflex and the center of the pupil are slightly different, then you have an angle kappa. So if you have a larger angle kappa, you will have some kind of a pseudostrabismus. So we were only worried about pseudostrabismus from a larger angle kappa, either positive or negative. But angle alpha is something very, very elementary. So angle alpha is the angle between the visual axis and the optical axis. The optical axis is nothing but the line joining the center of cornea to the center of the lens. So it is not the pupillary center, it is the center of the lens and the Hirschberg reflex, which represents the visual axis. So if you can carefully see the distance from the center of the cornea to the Hirschberg reflex, if they are very much different, okay, then probably you have an appreciable angle alpha. If it is more than 0.5 millimeters, it is normally measured in millimeters. But the equipments, the gadgets like IOL Master, and there are various anterior segment analyzers which actually give you a precise measurement of angle alpha. But I think it suffices for an youngster to see with the center of cornea and the Hirschberg reflex, are they very much different? If they are different, it's more than 0.5 millimeters, because when you put a multifocal, it centers to the center of the capsular bag, okay, which is actually different from the visual axis, which is much away, more than 0.5 millimeters. So this is going to completely upset the refraction or the so-called the diffraction that happens to the multifocal lenses, and you may not get an optimum results. So if you have a large angle alpha, more than 0.5 millimeters, it's a relative contraindication, and you cannot do anything about it. You can't center the lens to the visual axis, because whatever you do, once you put in the bag, it centers to the center of the capsular bag. So this is one important selection criteria for multifocal and a healthy TFL. I think this is very important. Dr. Partha just told that we need to actually look at the ocular surface, the amount of tears, the element of dry eye. That itself, if you've got a patient with a severe dry eye, that can add additional problems for the clarity of vision, and the multifocals can really be, not a great idea. When you go really back from the cornea, you go inside a stable capsulozonular apparatus. You have a patient who's got a subluxated lens, you've got a severe PXF with a shaky lens, or if the capsule is already fibrotic, or it is don't have a proper rhexis, it has gone away to the periphery. So if you do not have a proper bag which is stable, and also you ensure there's a long-term stability of the bag, I think it is not a great idea to put a multifocal, because the problem is once there's a displacement of the lens to one side, either because of an asymmetrical fibrosis or a phimosis, or if there's a tilt of the lens because there is a zonular dehiscence and the lens tilts to one side, it causes severe amount of, if a monofocal lens tilts, it only gives an astigmatism. It adds astigmatism to the existing refraction, which can be resolved into a regular astigmatism. If a multifocal tilts or an aspheric lens tilts, it adds additional problems like new aberrations, which cannot be corrected with spectacles. So this is something very important. If you you cannot ensure a stable capsule and a zonule for this patient for on a long-term basis, multifocals is not the way to go. I think it's very important to have a proper CCC. This is where the femtolaser second laser also comes in very handy. So if you are able to do a good CCC of appropriate size, for us, the appropriate size is around 5 millimeters. So we have at least 0.5 millimeters of overlap on the optic edge. And the shape, it has to be important. If the shape is too bizarre, you have areas which are not covering the optic, then you may have an asymmetrical fibrosis and a shift or a tilt or some kind of a change in the effective lens position. I think effective lens position is extremely important, not only for eyeball calculation, power calculation, also for the long-term performance of these multifocal lenses. And when you still really go still posteriorly, what is very important is the macula. I think the macula has to be absolutely immaculate. There cannot be a problem present or an immediate future. If you have a diabetic macular edema, if you have a CSME, if you have a CME, or if you have an epiretinal membrane, any kind of macular pathology, which you envisage is going to happen soon enough, so you are going to create a difficult situation, because you'll not be able to really help with multifocals already reducing the contrast, and a poor macular function also adding to the misery. But the most important, all the veterans here will probably agree, that is the psyche of the patient, which is probably most important. Having said all that, this is a patient who is, can be really unhappy, can really steal away your night's sleep. I think this selection is something, this is probably a simplest thing. Somebody who asks minimum questions, have minimum doubts, minimum expectations, minimum aspirations after spending a lot of money. I think this is a patient who is an extremely well-suited patient for a multifocal lens, which is unfortunately a rarity. So coming to the actual, the crux, monovision. So you have a classical monovision where we used to make one eye plano, the dominant eye plano, and the non-dominant around 2.5 diopters. The idea was to have an N6 or N8 in the routine reading setting. I think, but now we do not really need this kind of monovision for two reasons. Number one, our the distance at which we are reading has changed. The contrast of the material that we are reading has changed. We are more nowadays reading more from the screens rather than the printed material. So we are going to keep it little away. At the same time, there's an element of pseudo accommodation which can actually, you don't need to really cause such a different, refractive errors in the two eyes. So we have now into micro monovision or a mini monovision, where we make one eye a metrope and the other eye, the non-dominant eye, to be around -1 to -1.5. Myope should be an ideal way to go, and that has really proved very successful, causing minimum anisometropia. But the monovision is not without problems. I think this is since I also told I'm a strabismologist, I have, a greater idea of these things compared to an youngster, because monovision is a problem which is closely linked to ocular balance. Let me come to that. You're creating an anisometropia, an intentional anisometropia, and every patient may not take this kindly. The visual system may not take this induced anisometropia very kindly. It is going to upset the fusional mechanisms. It is going to upset our stereopsis mechanism. It is going to upset our ocular balance. The problem is stereopsis. Many patients do have a decent stereopsis with around even an anisometropia around 2.5 diopters, but many of them actually score less on a stereopsis. See, this is a clarion call for all young ophthalmologists. We only look at 20/20 as our aim. I think I add one more 20 to this. That is, as a strabismologist, I insist that we all should aim to give a patient 20 seconds of an arc of stereopsis. The stereoacuity, which is one of the important component of vision. So we should aim at giving the best stereopsis the patient can have. So the stereopsis, if you are inducing a monovision, you may actually, completely wreck the whole setting or the platform for a better stereopsis acquisition. And obviously, you need to use glasses. Obviously, you'll not be able to read every prints, the smaller prints, read off from the drugs prescription, things like that. So probably this may be a problem for some patients, because they may have to use at least glasses, if not all the time, at least sometime. I think looking at the ocular dominance, I think this is a very important thing. How to check for an ocular dominance is something that is asked in the exam, as well as it is something very important for us to decide about monovision. Obviously, you need to have some contraindication. Any tropia, if you have a tropia, if you have a manifest strabismus, your entire monovision principle goes haywire, because unless the patient is actively alternating between the emmetropic eye for distance and ametropic eye for near, or the myopic eye for near, your tropia actually upsets the entire scheme of things in case of it, and obviously it takes away all that we have been talking about a binocular cooperation. The patient has a previous squint surgery. Obviously, they will have a poor stereopsis. They may have a peripheral fusion and an alternate suppression, central suppression. The monovision may not really work that well. If they have even a phoria, if you have already a latent strabismus with pure fusional amplitudes, if you create an anisometropia, you may actually exacerbate these phoria symptoms, and patient can get into more trouble. If the patient already using a prisms, it may not be a great area. So any kind of ocular balance issues, be careful. So what do you screen for a monovision? It's a Worth-Ford dot. I think this is the simplest of the things that you can do. Please do it for a cataract patient. Okay, but obviously many a time the cataract is very advanced. This may not be possible sometimes. 4 prism diopter base out test is something which is also can be used to rule out a microtropia. Bagolini, this is the easiest. I think this, even a patient with a little higher degree of cataract can also appreciate this. So Bagolini stated classes for a binocular vision can be the easiest thing that you can do to before you think of a micro monovision. I think this question is something very pertinent. You can just ask, because the patient has bilateral cataract, you don't know exactly what was their visual status in the past. Just ask one question, open-ended question. Was one eye of yours weaker than the other eye since childhood or since the time you remember? This itself can be a good idea to rule out a patient for a monovision. I think if you have a monofixation syndrome, as I said, and long-standing unilateral traumatic cataract, where the fusion may not be possible for a long time, even after a surgery, people are amblopic and comorbid. I think this is one point which I would like to stress on. A lot of patients with Parkinson's, a lot of patients with old people who have so-called either an established Parkinson's or maybe an early Parkinson's, which they may not tell you sometimes, even they may not know sometimes, they have a problem with reading even with micromonovision, because the eye movements are also supposed to be, affected in a Parkinson's. The kind of fine saccade, the movements, bilateral cooperation between the eyes is affected even in Parkinson's, in Graves. So that can add to the problems in these patients. So what do we do now? I think this is something which is a question now. So now you knew about the problems of both the things, the tough or continuous. I think what do we do now? I think what is very important is we need to work on our patient counseling. This is something very, very pertinent. Every young ophthalmologist should be trained in how to counsel a patient to reduce patient dissatisfaction. So everybody needs a spectacle-free vision, ideally. But at the same time, there are some people, some occupations which actually require spectacle-free vision. There are some people who cannot handle their spectacles because of their simple, obvious reasons. There may be people who are into a lot of screen time. They'll be very happy and working at different working distances, like a kitchen, or maybe working on their mobiles. But even they have multiple interests and doing at different distances. I think the trifocals or the multifocals should be the way to go. There are people who are always, recommend position, sleeping all the time. So trying to read, it's very difficult to read with a bifocals, especially for people who are lying down or bedridden. So these are the people who actually are, ideal situations for multifocals. At the same time, you always have to look for the contraindication. As I told you, in the previous discussion, look for contraindications. So somebody who has a lot of expectation about their visual recovery, having chosen the package of a multifocal, I think may not be the right patient if you have explained all their doubts and tried to clear. Because it's a very simple thing. I think the easiest thing, what I do is, that I always tell the patient, you have to choose between the two things. Choose between the clarity versus the convenience. If you want the convenience of not using spectacles most times, then you may have to forego a small amount of quality of vision or the clarity, which I can probably always tell them about the photic phenomena or the loss of contrast sensitivity, which is a very small thing. Don't overdo that, so that patient may not agree to a multifocal at all. But if you want the absolute clarity, crisp vision, you don't mind wearing a small numbered spectacles once in a while, maybe 20% of the times, then you may probably go for a monovision. I think if you can, I think looking at the patient profile, occupation, and the requirement, and looking at the eye, I can always come to a conclusion. This can be a happy patient for a multifocal. Patients who do not have much visual requirement, expectations, people are hypermetropes. They are the best candidates because they will be very happy with the thing. Low myopes or a moderate myopes who are used to reading without glasses, I think they may not really be happy with the multifocal. You'll always look at the negative side of it. Hypermetropes are the best candidates for multifocal lenses because they're usually happy. At the same time, you also look at what is the distance that the patient wants to read. If you're looking for an EDOF lens, an extended depth of focus lens, I think, is it that requirement, that is the requirement of the patient, or the patient wants to read books all the time? So we may have to probably use a higher ad for such patients. I think the final cut is monovision requires a lot of workup. It is not that just any patient can actually get into monovision. You can do that. I think look at the ocular balance, which is very, very important. And obviously, the fusional difficulty the patient has preoperatively can worsen if you create a monovision. And I told you 20 seconds of an arc is the final frontier. You have to really look at that part also. So before you do that. At the same time, the spectacle independence. See, there are many patients. You should understand that there is an element of pseudo accommodation. A lot of patients who are 6'6" for distance with a monofocal also have a decent near vision without spectacles. They will read N10 very comfortably sometimes. It is because of three things. Number one, sometimes they have a very small pupil, which gives them the depth of focus, a pinhole effect, so that they'll be able to read without glasses. Number two, they may have some small astigmatism, myopic astigmatism, which has crept in, maybe 0.5 to 0.75, but they're still 6'6" unaided. That small myopic astigmatism can help them to read for near. And the third one is their aberrations itself. This is the better side of the aberration. The patient has a spherical aberration, which is uncorrected. A small amount of spherical aberration can actually help the patient to increase the depth of focus. He may be able to read for near without glasses. So this pseudo accommodation is sometimes which can help the patient. So whatever we do, many times patient may not really need glasses the way that we want. And at least in our kind of patients, not everybody comes and screams that why you prescribe me glasses. And the spectacle independence need not be kind of a thing that it has to bog down us heavily on us, so that we need to put a multifocal in every patient. At the same time, the flip side is we are missing the patients out for who can be much happier with a presbyopia correcting lens or a multifocal in the eye, for the reason of cost, for the reason of our fixed mindset, for the reason of not counseling them enough, for the various reasons that I can state that we are underutilizing the presbyopia correcting lenses in our patients, and at the proper counseling, with the proper meeting the patient's expectations, and with the proper preoperative and the post-operative communication, I think we can have a whole lot of satisfied patients, giving them the best of the technology. So thank you very much.
Thank you so much, sir. So this brings me to, what Dr. Mehta always says, one thing, you should always over deliver and under promise. When you're talking and you're counseling your patient, always have their expectations lower. You keep bringing their expectations down when you're counseling them. And then once post operatively, they get more than what you had actually, promised them, they'll always be better. Dr. Partha, sir, your views?
The first two talks were excellent. So much of revision that I could do. Dr. Ramurthy's talk as well as KP's talk. KP is a born teacher, and every time I listen to him, I remember that he had taught this, and I've forgotten. So even today, KP, excellent talk and a lot of learning. Having said this, the importance of the multifocal or the trifocal is really underutilized, and that's because for our pedantic mindset that we are still harboring, the change that we need to do, and the importance of not only the cost but the convenience to the patient. That way, we are nobody to judge whether this patient would go in for the expense at the cost of his convenience. So it is very important to give it to the patient, to tell that this is what we have for you. If you want this, it is there. If you do not want, this is there. So that importance, and it has to be dealt with conviction. And here comes the importance of the conviction of the surgeon himself for the trifocal or the multifocal. So it is not the fault of the manufacturer who is not doing that fantastic product that we are always looking to. No glare, no halos, everything. That stage is yet to come, but we are nearing it. And that every one of us have to believe that the importance of trifocal, multifocal is invaluable. And again, the question that always comes to the surgeon is, if you had to have your eyes done, would you go for a trifocal? Would you go for a multifocal? And then, we, with our pedantic thoughts, oh my God, I would lose my contrast. So at what age, what requirement I would have, it's not what my patient would have. So it's very important, as well as to educate as much as possible and to give the option, go to the Google, search whatever you wish on the trifocal, let them be fully confused, and then they'll come back to you and ask, doctor, what do you think is best for my eyes?
Very, very, very true, sir. I'd like to bring in Dr. Anshika here because Dr. KP, mentioned that in post graduation we're always taught that anybody who does night driving should not be putting multifocals. So, Dr. Anshika, I mean, since you're a postgraduate student right now, I want to ask you what your exposure to multifocals and monovisions is like in PG. Like, are you taught about this during your PG, or what experience do you have with it?
Good evening, everyone. Thank you for the question, sir. So, while we are taught about monovision and multifocals, and our institute also does offer multifocals as an option, and of course, we can opt for monovision. But I think, owing to the socioeconomic strata of the patient load that we get, multifocals at least are not used very commonly, and which I feel is a considerable disadvantage, because maybe 10 years from now, multifocals are going to be such a prominent part, if they are not already, of the clinical scenario and what is practiced. So I think that's something that we are missing out on.
Yeah. So yeah, in fact, I was going to ask you that also, sir, that the education level, whatever it is today, it's going to be much better than what it is now, 10 years later. So what we are telling our patients today and what patients are understanding today will be much different from what they'll be understanding 10 years later. So people who are not educated well enough, how do you deal with such patient? Like, for example, we have patients in which we counsel them for monovision, we do their one eye surgery, we correct it fully for distance, they're good for distance for that eye, and then they won't come back for the second eye for 6 months. That happens. You've planned it in such a way that you'll do the other eye like that, and they'll have a good vision for distance and near, and they don't come back for the other eye saying that, well, I'm seeing properly. So how do you deal with patients like that?
Rohan, you'll get all kinds of examples in life. You don't have to worry about it. You have a game plan in mind. Remember, the bottom line is patient is going to forget today, tomorrow, 3 months, 6 months. 5 years down the line, 10 years down the line, whether they have to use glasses, whether the whole experience of cataract surgery was smooth or not is what is going to be remembered. That little pain, little discomfort and all that is of no significance whatsoever. So don't have to worry about it. And what you really have to worry about is every patient really... Yeah, sorry, Partha. I just finished. Every patient, whether you like it or not, even after choosing the cheapest of the cheap, is going to tell you कि बाजू वाला तो चश्मा नहीं पहनता, मुझे चश्मा क्यों आया? So remember, I am a great fan of monovision if it's a monofocal lens, as KP was saying. No question about it. Whether they ask or they don't say, ask, I do monovision for a monofocal. And of course, everybody wants to be glasses free. Take my example, my own example. I used to have -4. I used to wear glasses. Now I don't feel like touching them. And the value of having done it, ask any LASIK patient. They used to wear glasses. But the moment they got rid of their glasses, it is not just getting rid of glasses. It was just beautiful life altogether. And you just don't want to wear them again. So this is something very universal. You have a small correction which is required or not required, that can be taken care of. But almost glasses-free life for 90-95% of your waking time is an ideal dream that we should try and achieve in almost every cataract patient.
So, Rohan, if I could just add two quick stories. So the first story is, most of us started with the refractive multifocals when we started off. At that time, it was something new, something really exciting. And then I think we pushed the patients a little too far and then said that you're going to get this and this and this. And the patients at times were very unhappy because of the actual persistence of glare and halos. And these patients, how many of them did we explant? If we look at our figures, in my practice of refractive cataract surgery, would have explanted just one. And that was a patient who was really annoyed, and we kept on waiting, we kept on counseling. After 8 months, he said, no way, doctor, you have to do something about it. And I explanted that. But all the rest of the patients who kept complaining, even today follow up and say, yeah, I'm fine. Maybe I have to wear this thin pair of glasses most of the time. So, this is the acceptance. It is the neurological aspect that comes in, which is important. Now, the other part of the story is a very recent one. One of my friends implanted excellently, excellent surgeon, excellent implantation, trifocal lens, very well centered, everything done. Initially, it was just a 0.5 astigmatism that had shown up in the keratometry done by the IL master. After the surgery, the other eye of the patient was 6'9" and 6. This eye was also 6'9" and 6. The patient, after 1 week, was 6'12" and 10 in the operated eye. Everything well done. Patient totally unhappy all the time, comparing right eye to the left eye. Why did I get it done? Why did you charge me so much? Why should I have done it? Why didn't you say this? Why didn't you say that? And things went on. Ultimately, after 4 consultations all over the town, and finally, when my friend said that you need to, take a look and say, so we did everything. We did the aberrometry, we did the eye trace, everything we did. And we really found out that there was a cylinder, 1.25 of astigmatism that cropped up. And with that astigmatic correction, patient achieved 6'6" and 6. Now, with such a lot of promises, what is very important is the promise that you make has to be true, has to be real, and good counseling. At times when you are in trouble, your counseling will not help. It is your colleague's counseling that will help. Yesterday, I sat with the patient for nearly half an hour, took him from one machine to the other machine, and at the end, I convinced her that, ma'am, go back, just give it a try. Do not do this and this. Your system will accept what you have. Let's not try and do too much. We can do a little bit of laser vision correction. We can get rid of this power, but you might also still have some residue either this side or that side. So, these things are eye-openers. We have to understand that whatever technology we use, however skillful a surgeon that we are, we might land up in some sticky situation, and thereby an honest counseling, a very true counseling is always very helpful.
Dr. Gaurav, sir, your closing thoughts on this topic?
I think what Partha said is excellent, and of course, it was a wonderful talk from Krishna Prasad. And my only thought is that we have stalwarts sitting here, and opaque cataracts even today. I'm so happy with with good optical biometry that our outcomes for multifocals are excellent now. Patient satisfaction is great. But whenever I see a patient coming with an opaque cataract, a white cataract, and I have to do a multifocal, and patient is asking for a trifocal or something, I have to just think twice. Like even if we are doing immersion, I sometimes get that thing that two reasons. That one is is the retina going to be good and healthy, and you're not sure whether this patient is going to have a healthy macula, and you're not confident. Number two, optical biometry is not available. Should you still proceed with a multifocal lens? So that's one thought, and there I typically tend to go either towards a monovision or maybe something like a eye-hands kind of extended depth lens rather than a multifocal, even if the patient is asking for one. So I just thought I'll quickly ask, like, Himanshu and Partha and Dr. Mukesh, would they be comfortable offering multifocal, trifocal implants to opaque cataracts with, you haven't seen the patient in the past, you don't know about the rate.
No, you are absolutely right. Your worry is absolutely on dot. If you haven't seen in the past, each word carries a lot of significance. If it's an old patient of yours because of COVID situation was disappeared, something else is not a non-diabetic and all, and still insist, you can go ahead with it. Because a white cataract, you do what you want, patient is going to be happy ultimately. But principally, yes, multifocal difficult. You may not get the correct thing, and you may not get the correct axial length, and you may be wrong in your exact biometry. So I agree with you. You tend to go for an eye hands or a monofocal.